Welcome. Please remember to scan the QR code and write what's happening in the liver so that you can ask questions later. Thank you to the CF Trust for running this important workshop. Less thanks for them asking me to introduce it, but for all the researchers that I shall be introducing. My name is Debbie McNeil. I'm a musculoskeletal physiotherapist, so I've always encouraged exercise. But more importantly, I'm a parent. Our involvement with the CF Trust started in 1993 with the birth of our second daughter, Izzy. Izzy was readmitted into hospital having not passed meconium babies produced, and was rushed to the Regional Children's Hospital with meconium ileus. They thought she had Hirschsprung's disease affecting the peristalsis, but having cleared the blockage, luckily with an enema, not surgery, they felt there was an underlying cause. "Kiss her," said the registrar as we were waiting for the blood results to come back, confirming the salty taste that she had CF. I can remember a flashback to treating CF patients on the respiratory ward. They had just mapped out the CF genome the year before, and we were told to go and enjoy Izzy. I've always believed in quality, not quantity, but it really hit home then. And not transferring my anxiety as a parent with a child with CF was tough at times. But we encouraged our daughters to do everything and said, providing they tried to follow their treatment, we would do the best we could to make sure they did. And they have. Izzy grew pseudomonas from 18 months and regularly had IVs, which I've learned to do at home. So after the first 24 hours of feeling a bit rough, she carried on back at school. She was always pale and skinny, sadly to the envy of her peers, another problem with teenagers, but a bit of a challenge for us and her. But she was determined. She is still thin, but not pale, and now a successful career woman, still enjoying her sport. She ran the London Marathon for CF in 2019 with a very good time, and had her last antibiotics for IV antibiotics for NTM in the autumn of 2019. In 1995, our third daughter, Lucy, was born. I must be one of the few mothers who cried when she first pooed. The meconium that Lucy also has CF. Despite being the same gene mutation, Delta 508, as Izzy, they presented very differently. Lucy rarely had lung infections and suffered from the endocrinological side much more. She did have a man-sized spleen, she was told. Lucy was diagnosed with CF-related diabetes when she was 14, on the back of a virus that didn't clear. She was treated with insulin like a type 1 diabetic. In 2018, having finished university and just starting her first job in London, she passed dark blood-stained poo, didn't feel well, and made a doctor's appointment. He sent her to the gastrointestinal outpatients at the local hospital, not a CF centre. She was young and looked well, so they didn't pay much attention to her until she started to cough up blood. Luckily, Lucy's very pragmatic and had a plastic bag. She was having a vascular bleed. Her boyfriend joined her, and we just made it to the hospital as she was rushed down to theatre. She'd lost about 4 pints of blood. The surgeon managed to stem the bleeding, but said to us it was likely due to a hepatic portal back pressure and severe liver disease. This was a shock to all of us, but on the IT ward round the next day, she was seen by the liver consultant and told that she would need a liver transplant. She couldn't face the transplant. It was a massive shock to her and for us, but we knew it was her decision and that we should be grateful for the 23 years we'd enjoyed. Thankfully, it was the bank holiday, and the gastroenterologist covering told Lucy that with the right medication, there was no reason why she shouldn't have a normal life again before needing a transplant. Lucy visibly improved with that hope and was transferred to her London CF centre and was back at work in 10 days. She is now monitored through her CF and liver teams there. She and Izzy are young adults. I have stepped back from my involvement with their care as they transition into adult CF clinics, but I started to look for the research into cystic fibrosis liver disease, and there's very little. This is why this workshop is so important. To use an analogy from a talk yesterday, Mind the Gap, I think this should be bridging the gap in research. Cystic fibrosis is a complex condition, but predominantly the research has been on the respiratory system. But with the introduction of modulators and the progress in care and the conventional treatments that I've seen evolve over the years, the life expectancy has increased, which is highlighting other complications of CF diabetes and liver disease. And we need to expand that research to treat these. I am so grateful for the work that the CF Trust, all you researchers have done, the amazing posters that you've put together. But please expand that research and find the hypothesis to this question. And it is with great pleasure that I introduce Michael Narkiewicz, I hope I pronounced that right, Michael, the Professor of Pediatrics and Gastroenterology, Hepatology and Nutrition at the University of Colorado and Colorado Children's Hospital, who will be speaking remotely from the USA on CF liver disease. What do we know? Thank you.
Thank you for that introduction, and it was a great story to lead in to this discussion. I've been given 10 minutes to try and tell you about all that is happening in the liver, and together with the organizers, we decided that I would try and set the stage for the key questions. These are my disclosures. My work with Vertex, the CF Foundation, and Up to Date is related to cystic fibrosis, but I will not be discussing issues related to that work. So we're going to start first with definitions. For many years, there have been multiple definitions of CF involvement of the liver, and that's actually hindered much of our research because you've been unable to compare outcomes across studies, across research areas, and even across registries. So 2 years ago, the European and North American Pediatric GI Societies charged myself and leaders in Europe to come up with uniform definitions. So I'm going to use these terms going forward. And we use the term CF hepatobiliary involvement. This is a new terminology that I hope is becoming more common, and it really describes the spectrum of liver and biliary involvement in CF. And we were very purposeful in saying involvement because not all CF liver involvement leads to adverse outcomes. The involvement ranges from mild to more significant liver enzyme abnormalities, imaging abnormalities by ultrasound, CT, or MRI. And as I said, they may not have any long-term impact, up to what the introduction described, which is advanced CF hepatobiliary involvement, and what many people still call advanced CF liver disease because it is really a disease. This is really manifest as portal hypertension, and it can have significant outcomes on CF. And I've highlighted some key points. Liver enzyme abnormalities are incredibly common. In studies that we performed in Colorado on newborn screen infants and in other areas, almost 90% of individuals with CF will have at least one and often more liver blood test abnormalities by the time they're 18. Well, clearly 90% of individuals don't develop advanced liver disease. Advanced CF hepatobiliary involvement, the mechanism is not well understood. There does, however, appear to be two different variants. There is a biliary cirrhotic form that typically presents in young children and adolescents. There's also emerging recognition of significant abnormalities of the portal vein and a portal venous vasculopathy that occurs, seems to be more prevalent in adults, but has definitely been demonstrated in children. Liver disease currently is the fourth leading cause of death in CF. However, the individuals who die who have advanced CF hepatobiliary injury often die from non-liver complications. Having advanced liver disease really impacts the entire body, nutritionally and in the pulmonary status. So how frequent is the description of patients with advanced CF hepatobiliary injury? It appears that about 7 to 10% of individuals with CF develop this, and they virtually all have severe mutations. And there is not a genotype-phenotype correlation with CF mutations, as you elegantly heard in the introduction. And I'll get to the punchline, but it's not one I'm incredibly happy about. The new therapies have really not impacted liver disease prevalence. And I'm going to say yet, because of who's really received these therapies to date. So let's take a deeper dive into the hepatobiliary features of CF. So on the list are the major areas that have been described. They range from cholestasis in newborns, usually associated with meconium ileus, all the way to multilobular cirrhosis. I've highlighted what I think are the 3 areas that actually impact outcome dramatically. Clearly cirrhosis, and this term nodular regenerative hyperplasia can also be associated with what we call non-cirrhotic portal hypertension. In these areas, individuals present with portal hypertension. And then for adults particularly, hepatolithiasis. That's a fancy term to say you develop abnormalities of the bile ducts inside the liver with areas of narrowing, and then you develop stones, and then you get infections and pain. It is almost exclusively an entity found in adults with CF. The oldest we've seen in our pediatric center was 17. These 3 entities should really be our focus in the future as to how do they develop and how do we prevent them, and if they do develop, how do we treat them? Well, let's take a step back and try to understand what is the presentation of advanced CF hepatobiliary injury. This is a study from Michael Knowles' group in the University of North Carolina. It was a worldwide collaboration. They went out throughout the world and they identified over 500 individuals with CF and advanced liver disease. And I really liked this study because they had 2 hepatologists who reviewed the cases, the biopsies, and other clinical material to classify these individuals. And it's very clear they all had advanced CF hepatobiliary involvement. 2 things to take from this slide. You will note that there are more males than females, and that's a consistent finding for advanced CF hepatobiliary involvement. You'll also note that the median age of diagnosis was about 10. Again, the story told at the beginning of this is very typical. Unrecognized or unappreciated splenomegaly is typically the first presentation. And you'll also notice there are very few individuals identified after the age of 20. I would provide a caution to this, though. This study really predates the much longer lifespan for persons with CF, and we really don't know what's going to happen to those individuals who are enjoying life between 30 and 60 and hopefully longer. So how frequent are the complications of advanced CF hepatobiliary involvement? These are data from the US CF patient registry. And you can see that there were only 809 subjects identified out of the 30-some thousand who had cirrhosis. And in those individuals, GI bleeding is actually very uncommon. And in that way, the story that was told is a little bit atypical for individuals with CF, although the timing was well. You could see that only 3% in the prior year of all those individuals with cirrhosis had GI bleeding, and it's equal between adults and children. You can also see that the most frequent finding is splenomegaly, something that should not be ignored. So what's the outcome? So variceal bleeding is a situation where varices or dilated blood vessels in the esophagus rupture and bleed and present as was just described. I couldn't think of a better lead-in to this talk. What you see here is the prevalence of GI bleeding over 10 years in individuals with CF who were identified in the registry. If I put this up for someone with alcoholic cirrhosis, the 10-year prevalence of GI bleeding would be somewhere in the 40 to 50% range. In CF, it's between 6 and 10%. So the prevalence of variceal bleeding is different. And this is one of the areas we don't understand. But I mentioned it's the fourth leading cause of death and all-cause mortality in advanced CF liver disease. This was written before we changed our terminology, is higher. So in the same study that we performed out of the UKCFC patient registry, we found that over 10 years, those same individuals identified with cirrhosis had a 40% 10-year mortality. During that same time, again predating highly effective modulator therapy, the mortality rate for 20 to 40-year-olds was closer to 20%. So you can see an almost doubling of the all-cause mortality rate. Liver-specific causes of death were actually rare. They were mainly cardiopulmonary events. Okay, so we're in a new era, and we're in an era of excitement with highly effective modulator therapy. And I've been lucky enough to lead several studies looking at the impact of highly effective modulators on CF hepatobiliary involvement. The first study, PUSH, was a prospective study looking to see if ultrasound could predict the outcome of advanced CF liver disease ahead of time. And although I'm not presenting that data today, I will tell you that we've developed an algorithm to predict risk based on your ultrasound finding when you're young and a simple blood test called a GGT. We took advantage of that study because it spanned the highly effective modulator therapy era to look at impact. PROMISE was the large US study looking prospectively at the impact of elexacaftor, tezacaftor, and ivacaftor starting in 2019. And there was, for the first time ever in the CF Foundation, an embedded study of liver. RECOVER is an Irish study doing the same thing, led by Paul McNally. And then we looked at transplant data from the US. So I'm summarizing a large group of data on one slide. So what have we found? Individuals who receive highly effective modulator therapy, and it's basically ETI now, elexacaftor, tezacaftor, ivacaftor, do have a slight improvement in their GGT to platelet ratio at 2 to 4 years. That test has been shown to be one of the best biochemical markers for advanced liver disease. In our algorithm we developed in PUSH, the higher your GGT to platelet ratio, the higher your risk for subsequent advanced liver disease. However, unfortunately, the things that we really care about, scarring of the liver, and I think you're going to hear about this test next, but there was no change in overall population values of what we call liver stiffness using a specific way to test for this called FibroScan. That's an indirect marker of scarring, but it really did not improve. We also found that ultrasound findings of individuals who had abnormalities going before they received ETI did not improve. Many of these data will be shown at NACFC this year. Well, what about the big impact? You know, we really don't want individuals to progress to liver transplant or to liver deaths. And so there was a group that looked at US liver transplants and lung transplants in individuals with CF across highly effective modulator therapy era, it's 2012 to 19, and then a shorter period of time, 2020 to 23. I would note that that did include the lovely COVID pandemic. But what they showed was in US lung transplants, prior to highly effective modulators, 12% of all lung transplants in the US were in individuals with CF. After highly effective modulators, that dropped to 1.5% or 1.6%. Unfortunately, and probably predictably, there was no change in the percentage of individuals with CF getting liver transplant or the number of transplants before or after the highly effective modulator therapy. I would note, however, that only about 12 individuals a year are getting transplanted for CF, so it's not a big end. I was asked to come forward with some key questions, and here are the key questions that I think are important for the future. We have to understand what are the causes of advanced CF hepatobiliary involvement. Is it one disorder? Is it multiple disorders? What is that? Why are severe mutations in CFTR necessary, but they're not sufficient for this? What are the other factors that affect advanced CF hepatobiliary involvement? I haven't reviewed the data, but there are a couple of genetic modifiers that have been found that contribute, but they account for a very small percentage of individuals. I think this is a really important question here, number 3. If we introduce modulator therapy early, before individuals have advanced liver disease or other therapies, can we prevent the development of advanced CF hepatobiliary involvement? The highly effective modulators have also come with a downside, which is a very small but real risk for severe drug-induced liver injury. Can we identify people with CF who are at risk for that so that we can help them through that? And then finally, why do persons with CF get fat in their liver? About 40% have significant fat in their liver, and this predates the modulator therapy, more after. And does it lead to fibrosis over time? I thank you.
Thank you, Mike. And questions for Mike will be answered at the end. And it was with great pleasure I introduce Neil Gahu, who's Professor of Hepatology, Facility of Medicine, Health Sciences from the University of Nottingham, and is actually here in person as to discuss non-invasive tools for assessing liver disease. Thank you.
So thank you to the CF Trust for the invite, and Lucy in particular, who reached out to me. So I feel a little bit like an interloper because I'm a professor of hepatology and I look after adult patients. I don't have a specific interest in patients with cystic fibrosis, but my area of expertise is non-invasive markers, and I suppose there's some advantages and disadvantages. Sometimes when people coming out outside your field give you a different angle or different thoughts and things, but I do apologize if I get some of the nomenclature not correct. I've already been educated this morning, and Michael's talk was very educative to me, so hopefully the principles that I try and put across overlap. So the burden of CF liver disease, and I'm using the old terms, and I appreciate there's a change in the nomenclature, but I think Michael very eloquently described the heterogeneous nature of this, and I think from my perspective as a hepatologist, what we really focus on the severe aspect of severe advanced liver disease, which leads to the complications, and 5 to 10% number resonates with the figures I think that Michael showed. The longer survival, just very simplistically, in the wonderful treatments that now come across in CF, become that liver disease is becoming more of an issue. And in fact, I see that in my clinical practice looking after general hepatology. We run specialist clinics. I don't do that. My colleagues run specialist clinics with the adults in the adult populations. The story about Lucy is very interesting because really the portal hypertension in adult liver disease is what drives the complications. And again, as Michael has beautifully eloquated, the portal hypertension in this condition is much more complex. It's not just simply related to the structural changes related to cirrhosis, but actually the venopathy that one gets may also be contributed to that. But it's very complex, and really the heterogeneity of progression, again, that the concept that's been put forward that one can't predict just because from a mutational aspect who's going to go and get advanced disease, means that we need to be able to have tools that track its progression. And the other aspect is, of course, with the patients living longer, they are exposed to, I would call the normal ills of life. So alcohol and increasing obesity that we see will be synergistic, and we don't understand what the synergistic effects of those conditions will, of those risk factors will be in this population. So in liver disease, we basically want to know how much scarring there is, because although it's an umbrella term, it's the scarring and fibrosis that drives advanced fibrosis and cirrhosis. And traditionally, we've used something called a liver biopsy, but really it's becoming inappropriate in most disease, and in particular CF, it's inappropriate because it's invasive, particularly in a young pediatric population. But also the nature of CF disease, which was patchy, means that sampling error is really a problem. So just to give you context, a liver biopsy measures 1/50,000th of the liver. So that's not really how you would want to ascertain. And this cartoon on the right really shows the sort of impact on that. So this is a normal liver biopsy. Sorry, this is the normal if you just took a proper transplant specimen. But if you take a biopsy and you take it from the middle of a regenerating nodule, you might not think there's much fibrosis. But if you go slightly to the right and get sampling error, you'll see the true impact of advanced fibrosis. So really it's important to think of the liver biopsy as being limited, not just in terms of tolerability, but actually in terms of the information it gives us. So there's been a real explosion in the field of non-invasive markers of liver fibrosis. When I came into the field, this is what I did as a PhD student in 2004. And really, we were told at that point, I was told as a PhD student, this is going to be something that's, going to be transitory, and the liver biopsy is here to stay. In most adult hepatology, we've now almost exclusively moved to non-invasive markers as a first line, and only for biopsy in certain situations. So there's a range of non-invasive markers that one can use. You can go from the right-hand panel of using serum tests. You can use something called the FibroScan, which Michael mentioned briefly, which is essentially a propagated wave that goes across the liver. Very interesting, the story comes from France. They used it to look at the maturation of cheese. So as cheese ripens, it gets harder. And so they used to use probes to see if the cheese was mature enough. So the French, being the French, extrapolated that to foie gras in the liver, and hence you got it. So it's basically built on the physical principles. It's nothing clever. It's just physics of elasticity and how quickly a wave goes. You've then got MRE, which is essentially elastography, but you get much prettier pictures. But you use an MR device and you use an external passive drive to drive that wave across. And then, of course, you can go to the metabonomics. And then on the bottom right, I'm just going to introduce the concept of using uncontrasted MR, which is different to MRE, and I'm going to show you some specific data on that in a couple of slides' time. So, So rather than go through all the studies of all the different markers, because I've only got 10 minutes and it would probably send you most of you to sleep, I just thought I'd create one slide, which I think is based mainly on the adult population of non-invasive markers, but I've tried to refine some of the principles for a CF population. So if we look at this table and go from right to left, we've already talked about the limitations of liver biopsy. Simple markers, the things that Michael's mentioned, using just normal liver enzyme tests. They're quite good in the adult population for looking at advanced fibrosis, but the limitations is that antibiotics, and in fact, the modulators that you use in terms of a drug-induced liver injury may impact on those liver enzymes, and they give you a false picture. But of course, they're cheap. And the panel markers, and what I mean by panel markers is that in the adult population of liver disease, we've got specific fibrosis markers, which are made from the biology of understanding extracellular matrix biology. So something called an ELF test, which uses hyaluronic acid, TIMP1, and MMP. And they could be quite useful. They are very useful in the adult population. But there's very limited data of that in the CF population, and I do wonder whether they would also pick up fibrosis in other organs, particularly in CF, which is a multi-system organ disease. So there might be limitations. The advantage of them is their variability is actually better than the simple markers. We move on to FibroScan that I've just talked to you about. Again, very good for advanced disease. But again, the problem is that CF is a patchy disease. And the picture we want to get isn't just simply about fibrosis, but all those other pathological aspects that Michael touched upon. Is there fat? Is there inflammation? Are the bile ducts affected? And things like that. So that a FibroScan won't necessarily give you that. And a FibroScan still has a sampling error. It's 1/50th of the liver rather than 1/50,000th of the liver. There are capital costs of getting the FibroScan, and you have to train the technicians up. Also, the issue that's coming out in the adult population is there's a variation of measurement. So the FibroScan, that stiffness measurement, can be affected by your meals. It can be affected by obesity. It can be affected by cardiac dysfunction. And so if you measure those serially, you need to understand what that variation is. And we need to show a change of measurement of greater than 30%, really, to understand that's not a measurement area and as opposed to disease progression or regression. And finally, MRE, which is, again, very good at significant fibrosis. There are some capital costs, but again, very limited data, both in the adult population. There's better data in the adult population. There's emerging literature on that, but there's limited data in this. But the real advantage of MRE and MRI might be the lower variability. So I thought I would just show you an insight into what sort of tools that could be possible. So this is a study that's been brought together by my colleagues at Nottingham. I'm not involved in this study, so it's quite nice presenting other people's data. And Nottingham obviously has a rich history in MRI, so Peter Mansfield got the Nobel Prize for MRI, so we've got some brilliant physicists there. But they teamed up with some names that you'll be familiar with, Alan Smith and Andrew Prale, who are CF investigators, but they also worked with adult gastroenterologists, adult hepatologists, and adult lung physicians. And essentially what they wanted to do is, in a pediatric population, understand how you could get a total body scan using MR. So this is a very small study. It's proof of concept, and it's only been published in abstract. But this is 8 children with CF and 3 healthy volunteers. They were put in a 3T scanner. They were, I quite like that. They were offered Netflix and Disney. That's how I'm going to get my kids' subscription down, I think. So, and no sedation was used for the MRI scan, and no contrast was used for the MRI scan. Okay, so it's quite important that for this population and an adult population. I think you'll see things running out of battery, or right. So this is the actual scanning protocol, and as you can see, the whole protocol is looking at the gut, the liver, the spleen, the pancreas, and the lungs. And I'm just showing you the data on the fasted abdominal scan, but of course these patients came back for repeated scans, fasting and unfasting, and to get other areas. But let's just concentrate on the gut scan, and I'm going to just show you today the data on the liver and the spleen. So here, what you can see is the top patient is a patient with CF, and the bottom patient is the healthy volunteer. And what you get is you get something called T1, T2, T star. You don't need to know what that means if you're not a radiologist, but essentially it's telling you about whether there's a fibrosis or inflammatory process going on in the liver, and it's giving you a global picture of where that's going on. To the right, FF is fat fraction, so we can look at fat in the liver, and we can also look at the stiffness in the liver. I haven't shown you data, but we can also, using these protocols, the physicists have created blood perfusion protocols. So you can look at perfusion within the liver and blood flow to the liver. So that allows you to measure non-invasively aspects such as portal hypertension, which are very, very important. So because this is a small study, you wouldn't expect to see a signal. But in this study, what they did find is that they found there was an outlier in their T1, T2 patients when they looked at the healthy volunteers and the CF patient. And this outlier wasn't known to actually have CF-related liver disease during the study. It was only afterwards that they went and found out that they did. So it shows you how sensitive this can be. T2 star looks for iron, liver fat fraction, I've talked about liver stiffness, and liver volume is also important, but you can also look at spleen volume. So why do I think that's important? Because essentially, we may be able to start looking, using tools at multiple organs in CF at the same time, but also different pathophysiological processes within the liver. And that's probably quite important for liver disease per se, but my argument be even more important in a condition such as CF-related liver disease. So the questions and challenges I put to the audience really are, do we understand the basic concepts such as of the prevalence, and I apologise for using the old nomenclature of CF-related liver disease. We've been told about the difficulty in the taxonomy, and I presume that's one of the reasons we have difficulty in understanding that, because we've had different definitions and different tools. So we need to do some longer natural history studies to understand that. In view of the complexity, do we need a bespoke approach to assess CF? And we probably need to think about using multimodal tools that are giving us different insights into different pathophysiology, rather than just using one tool. So you could have an aspect of, as a screening tool, you might have a blood test or fibroscan, that's fine, but then do you need more complex tools to monitor progression? And then how do we bring together the expertise in the UK and further afield to answer these questions? So thank you very much for your time.
Thank you, Neil. A lot of questions to answer. So I would just like to introduce Fotios Sampiasotis, who is a UK research innovator at the UKRI Future Leaders Fellow at University of Cambridge and honorary consultant hepatologist in Edinburgh's Hospital. And he's going to talk about using cholangiocyte organoids to understand liver disease mechanisms. Thank you, Fotios.
Thank you ever so much. I'll just share my screen. Can you all see my screen? Oh. I haven't heard anyone complaining, so I'll take that as a yes. Thank you ever so much for this wonderful introduction. And I'm really sorry I couldn't make the meeting in person. So I'm going to be chatting to you about some of the newest tools we have been developing for research in cystic fibrosis, liver disease, and beyond. Now, before we dive into the newest developments, I wanted to summarize what you've heard from my excellent co-speakers on what is cystic fibrosis, liver disease, and how it develops. So very, very briefly, in the liver, cystic fibrosis affects predominantly the bile ducts, which are these green tubes you can see in this schematic. They're a network of tubes in the liver which drain bile from the liver all the way to the gut, where it helps with digestion. And in the liver, cystic fibrosis works very similar to the lung. We've got the chloride channel, CFTR, which usually pumps chloride in the lumen of the bile ducts. Water follows chloride, and this way the bile is kept thin and flowing nicely. In CF liver disease, what happens is the CFTR channel breaks down, chloride is not pumped in, we don't have enough water, the bile becomes thick and viscous, and similar to the airways, we get bile plugs, which of course block drainage, bile buildup in the liver, and that leads to horrible scarring, and a lot of our patients end up needing a liver transplantation. And how common is cystic fibrosis liver disease? Well, we know that up to 1 in 3 patients, and you've heard all about it, will have some form of problem with their liver. 1 in 10 patients will develop very, very severe liver problems, and a lot of them will go on to have a transplant, which is not a minor operation and is associated with a 2 to 4% mortality in total in these patients. However, over the last decade, we've had exciting new developments, and of course, CFTR modulators are the new kid on the block. After these drugs, do we need to be doing much more research in terms of therapeutics? Well, I would say absolutely. Focusing on CFTR modulators, we know that all of our trials have been done in the lung, and we would really, really want we assume that they work very well in the liver, but we would really, really want to have a way to look exactly at what's happening in the liver. And in an ideal world, I would like to know exactly what's happening in the bile ducts. One could argue you can monitor your patients and see when they are going to progress to end-stage liver disease and get a transplant, but that will take decades. And the purpose of the meeting today is there a quicker way to get these answers? And then what happens when CFTR modulators are not working so well, if a patient can have them, if it's not a Delta 5 or 8 mutation? We would love to have robust platforms to develop new drugs. And I think in an era where we're talking about advanced therapeutics, why not move beyond new drugs and start looking at even more advanced therapies, such as gene therapy and cell therapy? And these are, I think, the three main areas I want to touch upon today very briefly. So starting with drug screening, us and others have developed a method to grow bile duct cells in the lab in a format called organoids. These are mini 3D bile ducts, which you can see here. There are cells all around, and this is the lumen of the equivalent of the lumen of the duct. And of course, all these bile duct cells pump chloride in the inside of the lumen. Now we can grow these cells from any biopsy sample, be it a liver biopsy or a gallbladder that's coming out. But of course, not everybody has a biopsy, so it is very possible to grow them even from skin samples using the technology of induced pluripotent stem cells, and I will not go into details on how that happens. But we can take a tiny skin sample and convert it into bile duct organoids. The next exciting thing is that when you look at these mini bile ducts in the lab, they can reproduce the disease phenotype, they can reproduce features of the disease. And of course, the most cardinal feature of the disease is the lack of a functioning chloride channel, a functioning CFTR. So when we stain for CFTR in these patients, you can see CFTR in a healthy individual is shown here by this red line. And if you've got cystic fibrosis, CFTR is almost entirely missing from your bile duct cells. And then we went on to develop assays to start screening new drugs. I told you before that when chloride is pumped in the lumen of the bile ducts, water follows, and the bile ducts increase in size. We can reproduce that in the lab. So in a patient with cystic fibrosis, these organoids have a very, very small lumen. And of course, if you try and correct the CFTR problem, if you try and restore the chloride channel, chloride gets rapidly pumped in the lumen, water follows, and you can see these organoids swelling. And it's a very quick and easy assay. It's very impressive the first time you see it. It happens in under 30 minutes, and you can see in front of your eyes which drugs work and which don't. But we also have more advanced methods. You can use chloride tracer. These are dyes which change color when the CFTR channel starts working properly and pumping chloride in the lumen of those ducts. And we developed all these systems over the last decade, and we've already tested some of the CFTR modulators with them with excellent results. So this is all about organoids and drug screening. But what happens when the bile ducts, in advanced disease, when the bile ducts have completely been destroyed because of the accumulation of toxic bile? Then you would need to replace them with healthy tissue. So we started asking the question, is it possible to use the same cells, these organoids, these lab-grown cells, to replace destroyed bile ducts with healthy cells? We started by doing these experiments in mice. Because we want to test human cells, we take immune-compromised mice. There isn't a very good model on the mouse of cystic fibrosis liver disease. So instead, we decided that we'll inject a toxin that destroys the bile ducts non-specifically. And then we injected our cells, which we had labeled with a red dye, so that we can easily track them to see, can we repair damaged bile ducts? And I think a picture speaks 1,000 words. I'll not go into details, but what you can see here in green is all the bile ducts in the mouse, and in red, you can see our cells, and you can see that a very significant proportion of the bile ducts of these animals have been repaired by our cells. But this data is all in mice. And as a clinician, what I wanted to do is we want to move closer to humans. So is there a way to do that? I was very lucky to work in Addenbrooke's Hospital, which is one of the biggest transplant centers for CF in the UK. And there we use a technology which is called ex situ machine perfusion in transplantation. What does that mean? When the liver is offered for transplant, it is put in a bucket of ice until we can take it from the donor and transplant it in the recipient. And the organ, of course, doesn't like it. It's cold, it doesn't have blood, it doesn't have oxygen. So a way to overcome this problem is to use these machines, which are called machine perfusion devices, and we put the organ in this bucket, and then we connect it to a circuit which can perfuse warm, oxygenated blood. As you can see, the blood is going through an oxygenator here. And then the organ starts waking up and recovering and getting over its cold ischemic injury. Not all organs recover. We had the opportunity to capture up to 10 of these organs, which we couldn't transplant in patients because of significant bile duct damage, and do exactly the same thing we did in the mice. So we started injecting healthy bile duct cells, healthy bile duct organoids, to see if we can repair the bile ducts in these livers. And you can see here, exactly as we've done in the mouse, that all bile duct cells are in green, our cells are in red, and where cells had fallen off and died, our cells in red came and repaired them, rendering the bile ducts functional. And most importantly, for the first time with this system, we can start looking exactly at what is happening inside the bile duct. So as you can see here, we can measure bile parameters. I told you before how chloride and water, how water follows chloride and makes the bile thin. You can see that when we start repairing the bile ducts in these organs, the bile volume starts increasing massively because the bile ducts start getting more water into their lumen. And that is a system we can use to test not only cells, but any form of therapy by measuring bile parameters, including the new CFTR modulators. I think that's enough for cell therapy. What about gene therapy? We know that gene therapy is still promising in cystic fibrosis. The most promising vectors have been AAV vectors, but we haven't ever had the chance to test them very extensively after initial trials, which showed reduced efficacy, or to develop new vectors. Now, we haven't done that for cystic fibrosis yet, but what we had, I'm going to show you some of the work we did in another monogenic inherited disease called mitochondrial neurogastrointestinal myoencephalopathy, which is a mouthful. It's called MINGI for short, and it's caused by a mutation, not in the CFTR, but in another gene called TIMP. And what TIMP does is it metabolizes nucleosides such as thymidine and deoxyuridine to nucleosides where they help with the buildup of our DNA. When the enzyme doesn't work, these nucleosides build up, they go in our mitochondria and they damage them, causing all the manifestations of this mitochondrial disease, which are neurological manifestations, problems with the muscles, problems with the gastrointestinal system. And most importantly, these nucleosides are so many in the cell that they start overspilling into the bloodstream and become detectable. Normally, nucleosides are not detected. So what we wanted to do is test a new AAV vector, which was very promising for this disease. However, this disease is so rare, we couldn't get enough patients to power a clinical trial. So instead, a very committed patient to research, she was going to be transplanted in Ademrux. She donated her liver to us so that we could explore whether this viral vector works. So we took the patient's liver, we split it in two halves, right and left lobe, and we put each and every one of these halves in one of these machine perfusion devices. Then what we did is we treated one half with a viral vector, and to make sure that everything we see is due to the virus, we left the other half untreated to have a comparator, what we call a control. This is what the patient's liver looks like once it's come out of her. And this is what happened after we started perfusing and giving the virus. I'm showing you here in red, just as before I showed you CFTR before. Here I'm showing you thymidine phosphorylase, which is the protein that's made from the gene that's missing. And you can see in the lobe which hasn't been treated, thymidine phosphorylase is not detected at all. And you can see how well we can see it come up following gene therapy. And then we started looking in more detail. Can this restore the function of the enzyme? And you can see here how low thymidine phosphorylase activity is before gene therapy and how it gets restored after. And clinically, does that make a difference. We were very lucky because when you perfuse the liver with blood, you can measure nucleosides, which is the cardinal feature of the disease, which is the test that we use to diagnose the disease. So as you can see, nucleosides in both the untreated lobe and the treated lobe started going up. But when you give gene therapy in the blue lobe, which is the treated lobe, you see that they peak, and then the virus kicks in and they start clearing nucleosides out, showing that actually this vector is very effective. We could also use this system to test the toxicity of this vector by measuring liver function tests. And ultimately, this data was seminal because we used it to get approval for a clinical trial, which is now pushed forward by LifeArc, and the first, this vector is going to be the first vector trialed for Mingy. So in the interest of time, I have to stop my talk here, but I hope rather than questions, I've given you an idea of three main future directions where I think we could take advantage of newest tools to look into treating cystic fibrosis liver disease. First of all is drug development platforms, and organoids have been there for a very long time, but now we have whole human livers that we can use to test and treat new drugs. And if we move beyond new drugs, the possibility of cell therapy and gene therapy to help us in the fight against cystic fibrosis. This is not work I've done on my own. There's a huge team of collaborators. I want to thank them all and thank you for your attention.
Thank you to all our speakers. Thank you, Photius, as well, for that. So, the questions. So this is for Michael. Hopefully he can hear this. Given increasing identification of fatty liver in people with CF and with 40% prevalence of overweight obesity in older adults with CF, do we need to consider whether intentional body weight, body mass loss could play a role in treatment as does in the non-CF populations? Hopefully that makes sense.
Yeah, I think that's a great question. The individuals with CF are probably not exempt from metabolic syndrome associated fatty liver disease. And I think historically the CF diet has been any calorie is a good calorie, any fat is good fat. So I think this is clearly something we're beginning to see in the US. I don't know about the UK in the population, and I've identified several individuals with classic metabolic syndrome associated liver disease with CF. So I think the short answer is yes, it's important. The difficulty we have is separating out hepatic steatosis related to CF. There are causes like essential fatty acid deficiency and other abnormalities, and metabolic syndrome associated liver disease. There seems to be something, and this is more for Photius, in the CFTR that leads to fat in the liver that we don't understand, because it's really a very common finding early without obesity. So it's separating those two processes, I think, which are the key issues.
Okay, thank you. For everyone, what should we be telling young CF patients to do to look after their livers?
I guess I'll start because I'm the pediatric hepatologist. Absent knowing the cause for young kids, I hesitate telling them anything in particular, but the things we do is we want to maintain a healthy diet and avoid obesity into adolescence. We'd like them to be adherent with their CFTR modulators, particularly if they got them young, because if it's going to have an impact, it's going to have an impact in those individuals. And then certainly as they get into teenage years, we counsel them for all of the issues that our second speaker brought up, that Neil brought up: avoidance of alcohol, vaccination against other viruses like hepatitis B and hepatitis A are still important, even though I come from the US where they seem to have forgotten that idea. But that's my answer in that space.
Photius,
Neil,
do you want to say anything?
I think I just want to emphasize what Michael said. prevention is way better than treating end-stage liver disease. And we see that for all of our advanced therapies. Our advanced therapies reach a point where they lose their efficacy. Whatever we do, there is no treatment that will completely reverse end-stage liver disease. So I think every day that you miss therapy early on, you pay money for it in the days to come. So the most important thing is adherence and follow-up. That's the other thing. We need to make sure they don't miss on their follow-up appointments so that we can intervene early.
Thank you.
Yeah, I guess one other thing I'd add is we just produced new screening and monitoring guidelines in CF to try and identify individuals at risk or early in the phase. So I think adhering to those, our goal is that that's actually going to help outcome. And we've added several things into the screening and monitoring phases, which we received some pushback from, but I think that's the next step for them. We still need a therapy. We still need to understand why this happens and identify a therapy. And I'll just say the historic therapy of URSO does not appear to prevent the development of this disease, which is unfortunate, but not surprising.
So there's only time for one more question, apparently. So this is from Lucy. Question for Michael and Neil. We know that the CF liver disease is a research priority for the CF community. What can the CF Trust do to help make an impact?
Neil, go first.
Does that just work? Yeah. So thanks. I think Michael can add to this, but I think one of the things all three talks have sort of outlined is our understanding of this has been limited because of the tools that we have. And I think therefore it needs, and these populations are still quite small comparatively. So I think there's two things for me. There's the establishment of national and international networks to be able to follow these patients up prospectively using the same data. And a bit like we heard in the talk before, in the session before lunch, sort of using multidimensional tools, because it might be that actually having an agnostic approach to this will give us greater insights for diagnostics and therapeutics.
So it just leaves me to say thank you. Thank you to all. Thank you for the research that you're doing, and thank you for the interest. Please make those links with your hepatology departments, with the liver departments, and expand that research. Interestingly, Lucy's liver function was completely normal when she had a vascular bleed. She doesn't have an overtly fatty liver, so I think it is the diagnostic tools that are the way ahead. And she probably missed out a scan on transition, but otherwise not. So thank you all, and thank you to the CF Trust. And as a parent, I really appreciate all the work that goes on behind the scenes, and patients may not thank you for that, but I, as a parent, really appreciate that, and they do too. So thank you all, and thank you for the progress that's been made over the years. May it continue.